Alô, bom dia a todos. Estamos dando início aqui a mais uma reunião científica do Departamento de Psiquiatria, em conjunto com o Centro de Estudos. E hoje nós temos o prazer aqui de receber duas convidadas dos Estados Unidos, da Universidade de Califórnia, que vão apresentar atividades de pesquisa e têm trabalhos conjuntos aqui com o pessoal da escola, junto com a Clarice Madruga. Clarice é professora afiliada aqui do departamento já de muito tempo, temos muitos trabalhos juntos, e isso provavelmente já faz parte de um programa já de segmento e trabalho conjunto com a Mariana e com a Joana. Mas a Clarice vai dar seguimento agora à apresentação e vai dar alguns esclarecimentos mais sobre essa apresentação. Só a título de informação, nós vamos fazer aqui uma primeira apresentação, as duas apresentações, e após as apresentações nós vamos abrir aqui as perguntas, não só das pessoas que estão presentes, mas das pessoas que estão nos assistindo pelo YouTube. Eu queria só mencionar e destacar que essa atividade que está sendo gravada, ela é patrocinada pelo laboratório FQM, que tem ajudado na divulgação dessas informações científicas. Imediatamente eu passo aqui a palavra para a Clarice, por favor.
Obrigada, professor Blay. É um prazer estar aqui, trazendo essas convidadas. É uma honra aqui para o departamento ter essa oportunidade de ter as falas das professoras. Eu vou inicialmente apresentar a professora Marina, que é a coordenadora e a pessoa que está acima dessa bolsa, que é com a Megan, uma aluna da universidade, que está aqui fazendo um trabalho com treinamento de manejo de contingências para profissionais de saúde, para atuação com jovens do sistema prisional. Então, isso é um trabalho que já está em andamento, a Megan está aqui baseada no Brasil fazendo a intervenção, e as professoras responsáveis estão fazendo essa visita para conhecer a estrutura, conhecer a universidade, conhecer os serviços e aumentar ainda mais essas possibilidades de colaboração. Então, eu vou inicialmente apresentar aqui a professora Marina em inglês, porque eu não vou tentar traduzir essa quantidade de titulação e cargos aqui. Então, Professor Marina Toulouse-Shams, she's Kilroy Realty Professor of Psychiatry and Vice Chair of Community Engagement, Outreach and Advocacy in the Department of Psychiatry and Behavioral Science da UCSF, da Universidade de São Francisco. She's also Deputy Vice Chair for Research in the DPBS, that you're going to say what it stands for us later. And Zuckerberg San Francisco General Hospital. So thank you very much. Please have your talk. Thank you.
Obrigada, Professor Madruga, and thank you everyone for having us here today. We're really thrilled, and we are really feel so welcomed in Sao Paulo. It's been really incredible, and I want to also thank our postdoctoral fellow, Megan Ramaya, who's working here and collaborating on a grant, gave us the opportunity to come and work with all of you. So DPBS stands for, it's our Department of Psychiatry and Behavioral Sciences. So today, I'm going to talk to you about structural racism and its influence on substance use in youth who are already in contact with the legal system. I have no disclosures or conflicts of interest to report. And before I talk about our work, none of it is possible without a team. And these are all of the team members, along with our funders, who I want to acknowledge: National Institute of Health, National Institute on Drug Abuse, National Institute of Mental Health. And this is a Bitmoji of our team. Our lab is called the Juvenile Injustice Behavioral Health Lab. So in the United States, there's a lot of discussion right now about not calling it a juvenile justice department. I don't know how this translates for Portuguese, because it doesn't feel like a very just system. And so we work with young people who are in the juvenile justice system, but we see many injustices. And this is why our name is that. Here are some pictures of our lab. We don't have maybe as amazing street art as you do in Sao Paulo, but we do have a lot of murals in our area in the Mission District of San Francisco, which is where our hospital is based. Broadly, our team works to develop empirically supported ways to expand access to mental health, substance use prevention, and sexual and reproductive health programming for young people who are involved in the legal system or in the foster care system, so who are removed from their home to be with foster parents. And since 2015, so before COVID, we have been studying how we leverage technology for good. In other words, how we use technology to expand access to care. And Dr. Folk is going to actually talk about that in her talk. But in order to do that, we need to study more expansively. And I know I'm speaking to a lot of professors with experience, much experience and expertise in epidemiology. Today, I'm going to talk to you about one of our studies that is an epidemiological assessment study. Here are some definitions, because we use words a lot in academia, and I'm speaking in English, and so I recognize they may not translate. So when I'm talking about system-impacted youth, I'm talking about adolescents and young adults through age 26 who've had some type of contact with the juvenile legal, delinquency, court system. The juvenile legal system in the US refers to family court, diversion, which means they come to an intake, then they get sent to the community, but they may be still monitored in some way by the legal system. Probation, which I think you are familiar with here. Detention center, and we have the opportunity this afternoon. We're going to go with the organization Mundaflora to visit the juvenile detention facility this afternoon. And community reentry. So once young people are detained, when they're released, going into the community. YILS, you'll see that on my slides. It means the population, whom we're talking about, youth in the legal system. In-home placement, we refer to that when a youth is involved with the court. They're monitoring the family, but they're trying to keep the young person still with the family of origin. Out of home or residential placement, they're removed from the home. And when we say behavioral health, we are talking about mental health and substance use prevention, treatment, and or sexual and reproductive health. I just want to give you some context for the juvenile justice reform in the United States. In 1899, the United States developed their first juvenile court. It was very much focused on rehabilitation. Young person was seen as someone that we had to take care of, parens patriae it's called. Then the second wave came along in the 20th century, and that's when due process rights came about to protect against self-incrimination for young people. In the 80s and 90s, we saw the pendulum swing the other way for the third wave, which was called the super predator wave for adults, and children were incarcerated at very high rates, and we saw the war against drugs, which was not effective, criminalize our Black and brown populations in particular. Now we're in the fourth wave of reform, and the pendulum is swinging back the other way, and there's intense recognition of the mental health and unmet mental health needs of young people in the system, and the brain science. So the brain science has informed that young people's brains actually aren't fully developed, their frontal lobe, their executive functioning, until they're age 26. And much of that has been brought into court decision-making around criminal offenses for young people. So the developmental science and also trauma-informed science on how we provide recommendations to young people, how we think about disposition. And just to give you a sense of what's happening in the United States, so do I have a point? Do I have a pointer? No, no, okay, sorry. Okay, so on the left side, you see a map. This shows you how the proportion of young people who are taken into residential placement, right? And the darker numbers refer to most proportion of residential placement. So you see a lot of light blue. We are removing a lot of young people from their homes, is the bottom line in the United States. And detention rates, as you can see on the right side, we still see massive disproportionality Black youth in the United States are getting detained at much higher rates than any other group of young people, even though rates are going down overall over time for the United States. Just want to show you a little bit because, for example, when I went to present in Ukraine, everyone was astounded to see how the US is the highest rate of incarcerating adults and young people, actually. And so just wanted to show you the disproportionality of the United States versus Brazil, for example. When you look at young people, the rates, Latin America, we couldn't disaggregate for Brazil for some reason, and maybe some of you might know some of these rates, but the US is still #1 for incarcerating young people. And Dr. Folk is going to talk a lot more about that because the project she talks about is related to young people who are detained and their families. This is just to give you a sense of the proportion of young people that are in the community. We still have many that are in detention centers, in long-term secure facilities. We have young people in adult prisons and jails in the United States. It's a big problem to us as child clinical psychologists. But we have a good proportion of young people in the community. Our team works with young people in the community with the hope of if we meet their behavioral health needs while they're in the community, we will prevent them from entering into the system. In the United States, our criminal justice system operates as our behavioral health system of care, which is highly problematic. And so why do we think it's important to focus on youth in the community? Well, what we find among a sample of young people who are going to a community-based court clinic to get a mental health assessment, we find that after accounting for age, gender, race, ethnicity, what their legal history was, what their psychiatric factors were, young people who come into contact with the court, who are in the community, who have both psychiatric and substance use, in other words, what we call dual diagnosis disorders, were approximately 6 times more likely than their peers to be detained 1 year later. So we have a lot of work to do to address those needs to prevent future system involvement, detention. And we see that girls are disproportionately affected. And they're disproportionately affected because of the high rates of sexual abuse in that population and trauma. So we need to be giving and thinking about delivering trauma interventions at the front door, their first time of contact with the system. So why youth who have first-time contact? Well, this is a description of how what we call in the US the sequential intercept model. What that means is different entry points, and same for you here, different entry points that young people have into the system. So intercept 1 is the law enforcement emergency services like the police contact. Intercept 2 is initial detention and court hearings. Intercept 3 goes from jails, right, or detention facilities. And I don't know, I forgot to ask Professor Madruga this yesterday, whether or not there are specialty courts where we have courts like, for example, juvenile drug courts, where young people who have a substance use related offense come to this court, and it's much more rehabilitative in nature, and they have to engage with counseling and therapy, and then they are basically their charges are dropped if they are successful in completing counseling. I don't know if you have those types of specialty courts here, but that can happen at Intercept 3. And then Intercept 4 is reentry and community probation. So we have a NIDA grant that is called Project EPIC, and that's in the green, and it's epidemiological project involving children in the court, and that's what I'm going to talk about today. So we enrolled 423 young people in first-time contact with the legal system in a single state in the US. And what I want to point out here is that we see the same disproportionality, even just at first-time contact, not detention, but first-time contact living in the community of Black youth. That proportion of almost 18% was double the census of that area. And then we see 44% almost of Latinx or Hispanic youth there, and that also is double the census proportion. And then what you see is a large proportion of these young people receiving public assistance, which means lower socioeconomic status, and 40% have an individualized education plan, which means that they have some type of learning need to address in the schools. High rates of trauma, 78% had at least one traumatic exposure in their lifetime. An average of 3 adverse childhood experiences. So that could be a range of different types of trauma exposures, including sexual abuse, physical abuse, but also community violence. And Dr. Folk does a lot of work in the ACEs area. And then we see high rates of suicidal ideation and attempt. So there's a lot of work to be done for suicide prevention in this population as well. Substance use, what does it look like for these young people? 50%, they're 14, I'm sorry, I didn't mention, they're 14 and a half years old on average when we measured this, first time contact. 50% have already used marijuana. That's very high. About 33% alcohol use, and other drug use was lower, 13%, but not insignificant. Yeah. So what's our approach? Well, our lab's approach and all of our work, you're going to hear more about this from Dr. Folk, but it's community engaged. We have a focus on health equity, social justice, and participatory co-design. So you'll learn what participatory co-design means, but it means starting from the beginning, at the beginning, building by and with for the community whom we're working with, whatever intervention or study we're working on. And we just got funded a couple of years ago for Project EPIC 2. And we use this eco-developmental theory where we consider the multiple layers around an individual at the family level, at the extrafamilial level, culture, neighborhood. And EPIC 2 was funded as a follow-up study to that baseline data, those baseline data I was showing you, to find a subsample of these young people now into young adulthood. 2014 to 2018 was when we collected the data that I showed you, and the young people. They were ages 12 to 18, and they were followed 7 times for 24 months in Project EPIC. And we studied across the first 3 layers, individual, family, and extrafamilial. And I'm not going to be able to present on those data today, but we have papers if people are interested in those factors in relation to their substance use, mental health needs. Project EPIC 2 was funded to find them at now ages 20 to 26 years old. And we are assessing them annually for over a period of 4 years. And now we're studying the macro level, the effect of structural racism, structural sexism, and economic inequality on these trajectories for these young people from early adolescence all the way into young adulthood. And we know that structural racism and discrimination is linked to a myriad of negative outcomes for these young people, including poverty, houselessness, mental health and substance use, educational barriers, lack of healthcare access, lack of employment, incarceration, physical health, and the list goes on. But what we don't know yet is what's the influence of structural racism and discrimination on first-time young people involved in the legal system, their adolescent trajectories of substance use, psychiatric symptoms, and reproductive health, as well as legal outcomes. We don't know what the influence is from adolescence into young adulthood. We have no idea. We don't have any data on this. And we don't know what the risk and protective factors are in early adolescence to help prevent these pernicious trajectories for these young people. So these are data that are brand new, very preliminary. We're really thrilled to have the opportunity to talk with you about them. And we welcome thoughts and feedback because we're going to have to do more analyses. But the way that we measured structural racism, so the state that we are working in where we collected these data in Rhode Island, I'm in California, sorry. The project was done in a different state in the Northeast of the United States. We had the opportunity to develop a measure of statewide structural racism. And so that's what I'm presenting to you now to show you how we measured it. So, whoopsie. Sorry, I didn't know I did that. So we had 4 dimensions to this measure. One is segregation, and that is made up of 2 measures, dissimilarity and isolation. And I'm not going to get into the derivations, but what is important to know is that we measured at the statewide level, and I'll show you with the map, but we looked at Black versus white segregation, and we looked at Hispanic versus non-Hispanic segregation. And in the United States, and in that part of the United States, the predominant Latine group is Puerto Rican and Dominican Republic. So, and so today I'm going to talk about the structural racism results related to Black versus white index comparisons. So we looked at segregation, we looked at education. So educational attainment gap, for example, was the ratio, the percent of the Black population without a college degree to percent of white population without college degree. This is an index, by the way, that has been published with other jurisdictions, locales. So we were using it here in the state. We looked at economic dimensions. So poverty status gap ratio, median annual household income gap, rental house percent gap, and employment. So what does the employment look in that particular area? Non-labor force participation and unemployment rate. Incarceration is a dimension of this measure. And these data that I'm presenting to you on the structural racism index is going back to 2014 to 2018, because we wanted to overlay what the structural racism score was with the period of time in which we collected those data as a first step. We will be looking forward when they're into young adulthood and calculating to see if these index scores change. Incarceration data were not available by census tract. So these are all census tract data calculated. So we unfortunately had to leave incarceration out. It's also a smaller state. So the variability, there's a lot of reasons, but so the scale is from 0 to 100. It's a ratio. Higher, more structural racism, lower, less. And what you can just see here down below, Black versus white, in the areas, there were some areas in which we couldn't well calculate the index. So there's a lot of methodological complications with doing this. And this is a first-time look at any of this for the US with this population. So basically, what you can see is there are a lot of dark areas. Those dark areas indicate high degrees of structural racism in those areas. And the yellow dots are participants and where they lived at baseline. So when they entered the study, and I showed you those use rates, right, for marijuana and alcohol, it's the address that they were at when they completed those measures. And you can see that we have a lot of participants who are living in areas that are dark, living in areas with high structural racism index scores. Okay, so how does this relate then to alcohol use that you saw? Okay, so let me just explain. We did some initial trajectories to look at the structural racism index score at baseline, where they reported 33% use. At the bottom are the 7 time points. So this is over a 2-year period. And on the vertical axis is alcohol use every 4 months, yes, no. So this is 0 to 1 representing proportion. So closer to 1, higher alcohol use. And what you can see here is that structural racism is related to high alcohol use for these young people. And we seem to have kind of 2 trajectories. We have one that's persistently high use for young people. That's the one in green going across the time points. They start off high, they keep going high, and structural racism, Black versus white comparison, is associated with that high trajectory over time. And then we have this de-escalating. So we have young people where the line is the use is going down over time. And below are for the colors, the proportion in each of the groups, the membership groups. So right now, we're in the process of trying to understand who are these young people who are in the high in particular, but we also want to look at the de-escalating because there might be protective factors there that we can explore. Oh, I just also want to point out, you're going to see that the sample size is almost half of what the initial sample size was. If you remember, I told you it was 423 to start, and it's 231. It's because we didn't have consent from everyone to use their address for geolocation. And actually now that we're finding them in young adulthood, we're getting the consent more. So by the end, we expect to have a higher sample. Nevertheless, looking at marijuana, it looks a little different. So we have, and the same is true for the time points and the vertical axis for marijuana use. So, but we see this persistently high trajectory that is associated with structural racism. So we're seeing high use at baseline persisting for this group of young people, of which 31% of the sample belongs to. It's not insignificant proportion. And then we see this de-escalating, but then we also see this escalating, the yellow line. And that's a concerning group, meaning we want to be able to understand what's happening there. But it's not the group that is being affected necessarily by the structural racism. So we're trying to disentangle this. But I think the bottom line is there's a high using group over 2 years that is impacted by structural racism. And that's really where we've got to start to look and understand. Okay, so next steps. I said the first one already, right? We need to understand the characteristics of the young people in these trajectories of alcohol and marijuana use over time so that we can inform interventions. So we are interventionists and we are prevention scientists. So we are very much, like your colleagues, very interested in taking these data and implementing interventions to address and in the community and with the courts. So these data can be very challenging because we don't know how the systems are going to react. We don't know the politics and these, so to be continued. Maybe we can come back and discuss that with you. We're going to examine the impact of structural racism on psychiatric symptom development. So here we just initially looked at substance use. And we're going to, once we finish collecting our data, because we're in active data collection to find the young adults right now, which has been incredibly challenging. And we're going to then explore the impact of structural racism early on in adolescence into young adulthood. We're measuring also their use of behavioral healthcare services in young adulthood, so we can see how structural racism impacts access to care as well. And then lastly, we are going to look at the intersectional impact of structural racism, structural sexism, and economic inequality. We know that those all intersect in impacting young people, and so we want to understand that and across development, so over time. So that is it. I'm not talking about the digital health work today, but Dr. Folk is. So really, thank you so much. And we'll do questions after. Yes?
I will just double check, but there was no questions yet. We were mentioning to perhaps ask the questions they would put online in between, but there was no questions yet. So I think we can go forward to the next one. Is that okay, Professor? Okay, so I introduce you to Johanna Folk. She is the Diversity, Equity, and Inclusion Champion Training, University of California. PhD Clinical Psychology, George Mason University, MA Psychology College, William and Mary, MBA in Psychology and Flute Performance, SUNY Potsdam College. It's a pleasure to receive here Dr. Johanna Folk, please.
Thank you all so much for having us. It's really been a pleasure, and we've really enjoyed getting to know your city. So I'm going to be talking about some of our technology-based work today, and thank you to Dr. Toulouse-Shams for giving such a great overview of how the system works. But we're also happy to answer any questions if any pieces are unclear, because there's a lot of overlap between how the systems work across countries, but not entirely. And I'll be talking today specifically about some participatory co-design work that we did with caregivers who have youth that are in juvenile detention centers. I do also want to just acknowledge our team and funders. You can see our lab Bitmoji. Again, we really like that one. Also, all the participants in the study and our community partners. So you heard a lot about how we over-incarcerate people across the lifespan in the United States. This is still a huge issue for us. And you can also see here that there has been a decline in terms of the number of young people who are in juvenile legal system facilities. Actually, about 75% decline between 2000 and 2022 is what's pictured here. And this is a snapshot for a typical day. So you can see towards the end, there was also a dip during the COVID pandemic where they were trying to reduce incarceration, in part to stop the spread of infection in facilities. I'm assuming it was similar here, but really widespread infection within facilities. And so they really moved to do decarceration more than we've seen, but going back up again, at least locally in terms of census. We still have really disproportionate rates of minority contact within the system, and particularly for Black, Indigenous, and Latina youth within our country. So you can see it still persisted in terms of this disproportionate rate of incarceration. That didn't change even during the pandemic with decarceration. So not everyone benefited the same from the reforms that were happening. We know that in our country, in particular, Black youth are at every intercept of the system experiencing worse outcomes. So they're more likely to be arrested. They're more likely to be adjudicated delinquent. At that point, they're more likely to be detained, whereas white youth are more likely to be diverted from the system. So you can see here, this is in a typical year, how many young people are in facilities. And I just wanted to highlight too, how much we are incarcerating young people for things like status offenses and technical violations. So status offenses in the US are behaviors that young people can engage in that are only considered to be illegal because of their age. So this can be things like drinking or truancy, running away, things like that. And so we're even incarcerating young people for that kind of more typical adolescent behavior. We also have a lot of young people in our immigration system and in the adult legal system and facilities. So I think this context is important in understanding the work that we're doing. These are just a few pictures of some facilities within our local area in California. So I'm not sure how much this looks like facilities you might have here, but you can see they typically look like adult jails and prisons, even for young people. The one on the bottom is a new room that was set up in one of the Bay Area facilities where they're trying to make it a more trauma-informed space. There's a bit of a movement around trauma-informed architecture and how you create spaces that are at least less dehumanizing, though I don't know that that can really fix a lot of the issues that we have. So I'm going to be talking a lot about caregivers and families today. And so with youth in the legal system in the United States, many of them are cared for by their mothers, their grandparents, kinship caregivers, which is similar to what you see in Sao Paulo in terms of that. We have a lot of grandparents as well. But we know that many teens in the legal system have mental health and substance use needs, which you heard about today. The rates are really high for youth who are detained. It's about 2/3 of detained males and 3/4 of detained girls who meet diagnostic criteria for a mental health condition, and about half who meet criteria for a substance use disorder. So we really have a huge treatment need for this population, and we're doing a pretty poor job in actually meeting it. So we have huge gaps in terms of access to services for youth in the system. We know that about 1 in 7 who need mental health treatment receive it. It's even lower for substance use, closer to 1 in 5. Presumably, when access barriers are lower when youth are in facilities, you would think that more young people would get the behavioral health care they need, but we don't see that. And we actually see it's around 15% who are getting care in facilities, and it drops down to under 10% once they're released. And so families are really critical in terms of helping navigate getting their teens into care when they go back into the community. They also, though, are not receiving the support that they need typically from the juvenile legal system. So for folks coming into contact for the first time, court procedures can be really confusing and really scary. And most people are not getting even just basic information on what to expect or how to interact with their youth's attorney or the probation officer or how confidentiality works, because different folks within the court system have different regulations around that. And so families are often excluded from conversations. And I would say it's the default in many of our facilities to not engage families. So even when young people are there, they don't know if their teen is safe. There's a lot of worries that come up because of the lack of communication. So there's a lot of need to support families who are going through this experience, because having a teen in custody can be incredibly stressful. And in general, we know that parenting stress, right, the stress of taking care of a young person, even if they're not in the legal system, can be related to how they are able to take care of themselves and their child. And we actually see it's linked to treatment outcomes as well. So when caregivers are more stressed, their teens are actually more likely to have prematurely drop out of treatment. And so this is a really important target for us to think about, even when we're focused on adolescent outcomes, is how are we supporting the family more holistically and focusing on helping caregivers manage their stress, both for their own well-being and also for the benefit of their child. So we have seen growing evidence that mindfulness-based interventions can be really effective in terms of reducing stress among adults. And there's evidence to show that this is true even for caregivers who have teens that are using substances or engaging in delinquent behavior. And we actually see that it has downstream effects on teen outcomes, where it can prevent the exacerbation of substance use, even if the teen is not participating in the intervention and it's entirely caregiver focused. So some promising data coming out around tailored interventions for caregivers using mindfulness-based stress reduction strategies. We also know that families and caregivers face a lot of barriers to getting into care. So when we think about the context that folks are coming from, it can be really challenging to even have access to reliable transportation or to go to an office to receive services. We see more in terms of like telehealth utilization, things like that, but people are often working multiple jobs, juggling care for multiple children, and it can be really hard to navigate a schedule where you have to go show up somewhere reliably. And so technology offers a lot of flexibility in terms of how people can access support. For caregivers navigating having an incarcerated teen, we also see really kind of high rates of shame and stigma that they experience, which can impact help seeking as well. And so they may not want to engage with a provider or may not feel like they're able to ask for that help for themselves. Or if they do, it may not be available to them. We have a really challenging kind of system of care for adults even who want to get treatment within the United States. So technology offers a lot of promise in addressing some of these barriers. And we also know that it's really important to actually design interventions with the people who you hope to use them, because this can really make them more acceptable and more helpful to people. And so we used to think about this idea of a digital divide as just who has access to devices, right? We now have expanded that to think about also internet access, but really participatory informatics takes this approach of who creates technology is also another form of digital divide, because if people's voices are being left out of the technology that's being created, they're not going to benefit in the same way from it. And so it's really important to be actively engaging with people, because otherwise we build things that people don't use and aren't helpful, right? And you download an app once and you delete it, right? So we need to really be thinking about this ahead of time. So I'm going to tell you about an app we created called the RAISE app. And this is something that we co-designed with a group of caregivers who had incarcerated youth. And I'm going to talk to you about the process of doing this co-design work and what came out of that, because I think it's really helpful to just think about, like, are people willing to engage in that? What kind of skills or expertise might they need for it to create an app that's actually useful? But I wanted to show you what we created at the end first. So the app here has a lot of mindfulness-based stress reduction content. This is something that caregivers actually naturally talked about as helpful to them and strategies that they were already starting to use, or that when they tried them out in sessions for co-design that they found to be helpful. So there's 8 weeks of content that people can go through where they learn different stress management strategies. It has some kind of didactic learning material, practice exercises. It uses a lot of mixed media, so lots of audio files, videos, images, like write-in options for text for reflection. And then we also have in the app resources. So specifically, we have information in there about how do you navigate the legal system. So how do typical court processes work? Who are the key players in the system? So what is a probation officer's job? What is the role of a defense attorney versus a prosecutor? And so they're able to kind of read about this and also store contact information for key people that might be serving their young people, so their young person. So it can serve as a tool for them as well in that sense. It also has some basic information about how to get mental health treatment if you need it. So let's say you wanted to find a therapist, where could you get started with that? And that was something that people found to be really important for them as well, as that resource section. So this is what it looks like. We thought a lot about the design elements. We went with a more cartoon style to the characters so that it felt more accessible to people. And I'll tell you a little bit about how we got there. So I want to talk just about the co-design process and what related to creating a feasible and acceptable application. So we worked with 6 caregivers of incarcerated youth. Half had a youth who was currently incarcerated while they participated in co-design, and for half they had been released within the past year. So for everybody, it was pretty recent and salient. So we ended up having to do this in a mix of small groups and individual meetings because of scheduling and staggered enrollment. But what we did is we met with folks for 9 meetings with myself and a research assistant and either 1 or 2 caregivers at a time, where we went through everything that went into this application. So starting from scratch, thinking about what folks actually wanted in an app, what kind of support needs they had, thinking about what interventions could be helpful, and then going through every single part of the content to be able to adapt it to make it feel more culturally relevant and accessible to a diverse group of people. This is just a little bit about who the co-designers were. So on average, they were 42 years old, predominantly women, which is representative of what we see for young people in the legal system of who their caregivers are. And they were ethnically and racially diverse. So after we had these 9 co-design meetings with each person, we also had user testing focus groups where we brought in another group of 6 caregivers who tested out the app and then participated in 3 monthly focus groups where they gave feedback about how it was working. A lot of this was about technical bugs, things that needed to be fixed in terms of the development, but also feedback on the content itself that we were able to integrate before launching a randomized control trial, which is ongoing right now. So we also measured throughout the co-design process using surveys and qualitative data that we did inductive thematic analysis on for the entire process. One thing I want to highlight is that none of our co-designers had any experience designing apps before and really didn't have any technical proficiency to do that. And so we really intentionally selected a platform where you can build applications with no technical expertise. And we had a really incredible company that we worked with, Chorus Innovations. It's really, you can like kind of drag and drop content to build a functioning app. They also had a design team that worked with us and helped to make it look beautiful, which was helpful because I think that helps with engagement as well. But the actual technical skills required to participate in this were none. I had never built an app myself before either. So even thinking about on the research side what that looks like and who you bring in as partners is important. And so this just highlights here, though, in terms of confidence that we'd be able to actually create an app that could be helpful to people. So when folks first started with us before the first meeting, confidence was about 83% that we'd be able to achieve that as an aim. By midway through the meetings, it was up to 100%, and that lasted until the end of the process. So This is just a little bit of kind of how the meetings went that I wanted to show qualitatively. The darker means that it was the focus of more of the meetings at that stage. But what I want to highlight is at the top, we really did a lot of collaborative exchange, which means there was a lot of going back and forth and sharing of ideas about how things should be working and looking within the group. We did a lot of content review throughout. And then at the bottom, you can see this real focus on trust building, which was really important because we're asking folks to share about very personal experiences in their life and to use that to create a tool that hopefully could help themselves and other people. But really, people were trying out the strategies themselves and learning therapeutically from it, as well as trying to contribute and give back. So trust was a really important thing, especially thinking about how the system often does not foster trust, right? And how betrayed people can feel by that. So people talked a lot about the challenges that they face when their child is incarcerated. I just wanted to highlight a few. A big one that came out was related to stigma and judgment. So I just have a quote here where it just says, they're talking about, oh, this kid wouldn't be doing this if you hadn't raised them in a domestic violence situation, right? So really feeling blamed for their own traumatic experiences. Another one saying, some people, they were like, that's your problem that your kid got in trouble. You were working, right? Like you can't expect people not to work. How do you support your family? And then they get blamed for their child being in trouble, right? People also talked a lot about safety concerns while youth were in the facilities. It's because of lack of communication in part, right? And also because there are real safety issues in facilities that people are dealing with. But even things like access to treatment or lack thereof was a challenge for caregivers. So often what will happen is they won't get any information about treatment except if medication is needed that they have to consent to. So they may get a call that they now have their teen getting prescribed sleeping medication. And if they have a history of substance use, caregivers can be concerned about how that's being used, right? So I think the lack of information can be really problematic. They also talked a lot about challenges when the youth was re-entering the community, right? And so thinking about concerns about access to treatment, again, being a big one. So here, this one is really highlighting about how they really know that they are the expert on what their kid needs. They may not be able to navigate how to get them the care within a complicated system, but really like also trusting yourself and being willing to advocate with professionals for what their child needs. Other things that came up, again, related to concerns about youth well-being and safety, going back into the same neighborhoods with the same peers where they might get into trouble again. I will say all of these teens for these caregivers had a history of using substances. Many of them had co-occurring mental health needs as well. And so they worried a lot about their kids going back into using substances again in the community and not getting the support that they needed. They also talked a lot about their own needs for mental health support and how that wasn't being met. So you can see a quote here just saying, especially when your kids or systems involved and you've got all the pressure making you feel like every decision that your child makes is your fault, right? You know what I mean? And they talked about anxiety and making it harder to provide for their children's needs, really this unmet need related to the stress of being a caregiver, right? Which if you have children, you know, there are stressful times in general, and then layer on surveillance from the system, being separated from that, it can really just exacerbate that. They also talked a lot about like kind of lack of culturally responsive services within our mental health care system. So we talked a lot about disproportionate contact for Black and Latina and Indigenous youth. We don't have enough providers who match those demographics, right? Or who are able to provide culturally responsive care or linguistically accessible care. For folks who are Spanish speaking or other languages, they're often having to rely on interpreters to access services, which can impact the quality of care that people receive. So we have real workforce issue as well. People also talked about what they thought could get in the way or help people to use an app like this. And so they talked a lot about privacy and how do we make people feel safe putting their data into an application like this. part of what we ended up doing is creating secure login systems so that people could feel like they could reflect and someone can just access their information. But another big part was how we emphasize that this is completely separate from the legal system and the court. So they have no access to the data. We partner with them in terms of getting referrals for our study, but they're never in the system at all in terms of the application. People also talked about just how it's challenging, though, to fit like these new practices that they were learning into their daily lives, and talked about how even like taking 5 minutes to take care of themselves at time could feel really not possible. So talked about how they kind of drain themselves and the importance of that. And so what they ended up wanting to build in was actually motivational messages that get sent out to the users that were written by the caregivers who co-designed the application to encourage them to use it, and also just as positive affirmations. There's also a reminder system in the app in that we do daily ratings of stress and mindfulness that caregivers can respond to. So we also have that daily data from the text messages, but that serves as another prompt to log into the app and to think about using the strategies. And people talked a lot about kind of what they hoped folks would get out of this app. Big one being learning tools to manage stress. You can see here, I think that your app is going to be able to allow people to have those grounding exercises that they don't get to do when they're just at home. Talking about managing their stress so they don't take it out on their kid or on themselves. And feeling like they're not alone. So just knowing that this kind of an app existed felt very important to some people, and that it had been created by others who are going through a similar life experience. And so we also have a testimonial video in there with quotes from the folks who designed it about kind of how they hope that this will help people in their experience with the content. So overall, we found doing this co-design work to be really kind of positive and collaborative. There aren't published studies of designing apps with caregivers who have incarcerated young people. And so I think it was a question as to whether people would be willing to engage in what would come out of this process. And really, the caregivers' lived expertise and evidence-based practices drove this. And that was really kind of the unity that came through the co-design of having folks who are in mental health and knew the scientific literature, and also people who have been through this life experience, and truly treating those as equally valuable and weighting even heavily the lived expertise piece. And really important to the caregivers was just making it feel culturally responsive and accessible to them, because most services are not designed with that in mind. And limitation, we had a small group. It was 6 people who co-designed it, 6 who did the user testing. So we're not able to capture, obviously, a full range of experience of people, since there's a lot of diversity of who comes into contact with the system. But in terms of next steps, we are doing a small randomized controlled trial right now of the app. And so hope to have those results soon to see if it is actually helping people manage their stress, and also looking at youth services access as a key outcome when they go back into the community. And we're also getting ready to translate into Spanish, which we're really excited about. We got funding to do that. And so in the process of doing that translation now. All right, happy to answer any questions. Thanks.
Thank you very much for your presentations. It's very enlightening. And I think it's very impressive, both presentations. First of all, Marina, you said about the huge amount of people there are within the legal system in the United States comparing with other countries. It's very impressive, this one. And I also would like to know some information about the question related to incarceration in different states in the United States, because you live in California, and we know that in California, people are free to get drugs, for marijuana including. Is it any difference between the kind of investigations or the data you have in different states, United States. I mean, is it the same in California and different states that the people are not allowed to get drugs?
This is a great question. So, no? Oh, in Portuguese?
Yes.
Yes.
A respeito da questão ligada a diferentes estados nos Estados Unidos, onde as drogas são liberadas em alguns estados e outros não são. E eu estava perguntando se os resultados seriam semelhantes em diferentes estados. E essa era a pergunta que eu tinha comentado, por favor.
So, in terms of the legalization of marijuana, yes, it definitely differs by state. And as you mentioned, states like California, Oregon, Washington, there are others. For young people, it's very interesting because technically it's not legal for young people, period. But that gets ignored. And the data, I don't actually know in a deep way the data around the impact of legalization on use. It's mixed, I know that. So in some states like Colorado, for example, I know they were looking, for example, data also in terms of legalization of use and how it related to truancy or school absenteeism. And so they're trying to understand how the legalization may impact other relevant outcomes for youth. And some of you may know more. I don't know, Joe, if you want to say anything more about that.
Maybe Dartil can help me out with the data, but as far as I know, there was no increase among the adolescents in California state, at least that was the first that had epidemiological data, right? But I think there is okay, but just to check with you first. Enforcement is very good in the States as far as we understand in Brazil. So I think that's also related to how things are seen when it's related to adolescents, minors, underage.
Enforcement of, the laws or?
Access, and even though it's legalized, the access, how they have access to.
Is limited?
Is it?
Not really. I don't think, I mean, on the surface, yes, I think, but I
We see
think
the
they're able to get, I mean, most young people get the drugs from their families or their friends. So to the extent that they make networks or connections or a family is also, and so that's where the legalization, and I don't know the data on that, about what happens with families in states that legalized that are using cannabis or marijuana, to what extent that increases the access for the young person. But if we look at it in parallel with opioids, which in the United States is a huge problem, pills, young people, adolescents get, in the past were becoming addicted to pills because they were taking it from the homes in the medicine cabinets and that sort of thing. Fentanyl is different, but yeah, so it's a good question.
And I would like to, I'm sorry. Seu nome, por favor.
Hello, I'm Angelo. I'm study here. So I have small questions for you. What is the adhesion for the app in the population? Is like the six people there that uses? It's not. Is that open to other people use?
Yeah, great question. Right now, it's only open to people who are participating in the study because we are doing this RCT to evaluate it right now. The hope is that though it could be integrated within systems and freely available to folks, that's really the ultimate aim.
Okay, thank you.
Yeah.
And in your presentation, we have two graphs. So there's a descending curve and these trajectories. What is the difference in the colors there? There were some percentages in the bottom. I didn't understand that.
Sure. Yes. So great question. So those lines, the colors represent the groups that the young people fell into in relation to their alcohol use or their marijuana use over time, over 2 years, as predicted by the structural racism score. So there's so the green line in both graphs is really the group that we're most concerned about. That represented, I can't remember offhand, but it was about 30% of the young people who fell into that group of high alcohol use, high marijuana use, separate groups. They're not necessarily the same.
So they were grouped by the usage of the substance or by the structural discrimination index?
Yeah. So structural racism score was associated with them being in the high use group of alcohol. So their alcohol, if that makes sense. So it was an association. Right now it's a correlation. We haven't done the regression models to understand what are the characteristics associated with it. But it was just that the structural racism score, a higher score, was associated with consistent high use for those young people, which was like around 30% of the 231 youth, like predicted in that.
Okay.
Does that help? I know it's confusing. I'm confused. They're really complicated analyses, but these, I can tell you, were very simple correlational analyses in terms of looking at the relationship between structural racism and their use over time.
Okay.
Yeah.
Thank you.
Two questions, just because it's related to his question as well. I was curious, you mentioned the structural point of view of seeing intersectionality, how it affects structural racism and how it would affect drug use as well. I was wondering, we have a similar project here with racism and also not related to drug use, but mental health in general, and we are planning to do those analyses using the national data. And I was wondering, do you have access to other ecological data from other systems? In which level of data could you have if you're planning to have that for this project, or if you already have, what type of data you would use to combine to see that intersectionality?
Yeah, that's a great question. So we are collecting data. I didn't make this explicit here, but from the young adult and their caregiver. And the caregiver may not be involved with them still. And each of them are completing series of measures in each of those domains. So we have family level data. Now it's all self-report. So it's self-report of the caregiver, self-report. But we have caregiver data. We have data about the caregiver's psychiatric needs, for example, family level data about their communication, about their emotion regulation, like how conflict, for example. And then we have, like, when they were younger, we have school level data, school reports of, we have all of that. Yeah. And the, so not when they were adolescents, we did not have the, what we call collateral, right? The services data. Young adults, we're partnering with the state to get data on who has been accessing behavioral health services. I know, that's the focus of your project. So it will be great to think about ways to collaborate on that. Now, the one downside is that if they go out of state, so now, we're following them. We stopped following them in 2018. Now here we are again. We started in 2022. So there's, a good 4 to 5 years between having tried to reach them. And if they go out of state, we won't have access to the services utilization data because we can only have it for the state that they were. Yes, it's a small state. So that's one of the benefits. Yeah. Yeah, to learn to how to understand this. Yeah.
Parece que tinha alguém que... Pode dar o microfone lá para ele, por favor? Ah, já está.
My name is Alec. I'm not studying here. I'm graduating med school, and I have a question.
Congratulations.
Thank you. I have a question for you, Mariana, on the same topic of those graphs that you showed us. You said you don't really know exactly why there was an increase or a decrease on
Not yet. Yeah.
either marijuana use or alcohol, but do you have any hypothesis on why exactly those are happening? If you would have guessed,
Yeah.
because there were groups that were on they were classified as very structural racism, but they
Yes.
went down.
So yes, so thank you for that question. So we did look very preliminarily. I didn't present it at the bivariate level to see, for example, was there a difference between female identified versus male identified. We had, I think, only 1 or 2 participants that identified as trans. I just want to point that out. So, so we looked preliminarily at when they came in for first-time contact. They either came in with a status offense, which is what Joe was talking about, right? So in the US, I don't know if it's the same here, but in the US, there are certain things that young people get in trouble for, but just because they're underage, right? So alcohol use, that sort of thing. So 50% of the group of young people came in with that type of petition or behavior, and then 50% came in with a delinquency petition, which meant stealing, assault, breaking and entering. And there's a little bit of a trend around that, that the youth who are coming in with the more severe first time offense seem to there might be a trend for them to be in the high using group, for example. Now, this de-escalating group is really, and the ones that are crossing each other, right? And I think there are likely to be family protective factors there. We do a lot of family-based intervention, as you heard, and so we're really curious to understand what might be going on, whether it might be about communication, parent-child communication, for example, about substances, whether it might be reduced conflict. Yeah, we'll have to see what. And also, we had a very small recidivism rate in this sample. So very few, I think it was 12 to 15% of this group of young people ended up re-entering the system. We don't want anyone to re-enter, but compared to other studies where, young people have been detained and they're coming out in the area, in the state that we're in, the recidivism rate was upwards of 60 to 70%. So there may be other protective factors that are affecting also, they're in the community, it could be school, it could be any of these, things. But I think, I don't know what you think, but I think it's family. I think it's family related factors.
Tem uma outra pergunta ali, por favor. Você pode se apresentar, por favor?
My name is Augusto. I'm a master's student, and I have a bit of a selfish question, but about the process of co-creation and co-designing the intervention. From the way it was described, it seems like a very free-form type of process, but was there some sort of protocol or a more structured type of way to perform that co-creation or co-designing? Because the project I'm a part of does utilize the co-creation type of ordeal, I suppose. So it's personal interest, really. Thank you.
Yeah, it's a great question. So I mentioned that we had kind of some people who went through the process individually and some in pairs. It was half and half. So we had 2 groups of 2, and then the other 2 went through individually. And so each person followed a really similar sequence where the first session really focused on getting to know what their needs were, building trust, understanding what they might want in terms of support, how they feel about technology, right? So more of that kind of background work that you might do. And then towards the end of that session, we really introduced more concretely the idea about building the app. Then in the next session, we actually would present the platform itself and how it worked and show people like how might you create an app. And we did a little exercise where we would like on the spot have them make up some kind of app that they would want to create so they could see the functionality. We also in that session talked a lot more concretely about what types of practices and strategies might go into that. And really, I was surprised by how many people kind of naturally brought up these mindfulness-based stress reduction type strategies. And so that fit really well into the protocol that we had hoped or thought might be useful. And so then from there, we really focused on going through in order. So we adapted an in-person mindfulness-based stress reduction intervention for caregivers to be self-guided on the application. So we took it session by session and went through all of the content from there, and people reviewed it. Kind of peppered throughout that was talking about more of these design elements. So as we went through exercises, okay, how would you want this presented? Let's look at mock-ups of images, play different recordings of voices, things like that. And so that was kind of the remainder of the sessions. So I think some structure is
Clarice?
helpful. Yeah.
Thank you. Just a curiosity regarding community engagement, because I'm just trying to figure out how it works within a small community, or if it's a medium community, which strategies, or whether you measured how to, share the knowledge about, advocacy about how to use, because I think adherence, it comes to the biggest challenge, right? To get people to know it's available and to use. So first question is whether you used any of the community engagement strategies or frameworks to spread out within the community about the app, and also just do two in one, if you don't mind.
Yeah.
Whether you had people from UX people, because in projects here, we've been trying to collaborate with professionals that are not from psychiatry or health sciences at all, but it was a massive, amazing jump in development when we got to collaborate with UX people that are from the technologies, and they even use other tools and other strategies to make it more useful or easier to use, or whatever. It will attract more attention and get more adherence from this, population that we want to reach.
Yeah, these are great questions. I'm going to start with the second one first. So with the UX, so we did have a technology partner. It was actually, the platform was developed by a psychiatrist at UC Los Angeles, and then he left and went into industry and formed this into a company. So he had his own kind of mental health and UX background, built this platform, and then has really grown a team. So we did work really closely with them. We would have them come into the meeting usually once as more of an intro, sharing about the platform, sharing about their expertise. And then other than that, we met with them outside of meetings with the caregivers, and we would talk through different ways to present content and material. They'd come up with mock-ups that we would then go back to the caregivers and show them. And that was a really nice way to do it, where we could have those kind of more in the weeds discussions around what it could look like and possibilities to present back. I think it does make a really big difference in terms of how people can proceed through the content, right? There's a lot of things just even about like, where do you place the buttons and what should that button do, and the flow of content and design that can really have a huge impact on user experience. So having solid partner in that sense is really helpful, and they don't necessarily have the content expertise, but again, that's part of that kind of co-design team more broadly. In terms of the community engagement, so I didn't talk about our work with the systems more actively. So we also, as part of this study, did focus groups and kind of working groups with systems professionals. So with folks in juvenile hall and probation. So we got a lot of referrals directly from the system for these co-design participants and also for the trial. But we go out to family visitation in facilities, and we'll sit in the waiting room and we'll talk to folks about the opportunity, Also just kind of building trust and rapport to get to know folks in that space. So even like showing them how lockers work or how they fill out paperwork, right? Because actually a lot of systems don't even have that, and it can be quite a confusing experience. So we do outreach in that way. We also have a caregiver who had their teen in the juvenile legal system on our team, who will go out into the community and meet with folks, goes around to all different kinds of organizations, and we go to kind of outreach events, things like that. So that's really how we've gotten people to enroll at this point. Very active. It's not easy. We've tried to do social media recruitment, which has worked for certain projects that our team has done. And then also I feel like recently we've gotten a lot more kind of fraudulent signups from social media. And so that's been a challenge. So we kind of backed away from that too. So more of the in-person recruitment.
Mais alguma pergunta? Hã? Sim, temos tempo.
Another curiosity, sorry. I had so long with you yesterday, but I still have questions. Regarding high risk, detection of risks, like for instance, I imagine the app would also present some level of profiling and risk assessment. I don't know. So first question, risk assessment, suicide, for instance, high levels of depression. How would you deal with it with a system that that's the second question. How to refer in a system that is not like ours, that is public, that we can easily, say, go to your next surgery that you're gonna have assistance. How would you deal with it?
Yeah, it's a great question. So this app does not include risk assessment or assessment in it actually in general. It's really just a tool for teaching the strategies and resources. And we're very clear from the beginning that it's not a live person that they're interacting with. It's entirely self-guided. So we're not asking questions in there about risk. We do in our assessments ask about mental health needs for the caregivers. And so we do get that information, but not about suicide directly in this study. We do, though, monitor the free text responses. People can text back to the app when they get these daily rating questions. So we do look at that, and we have protocols in place around if someone puts something in related to risk, we will follow up and do an assessment with them. In another project we have where we co-design an app with foster youth, there are actual clinicians and service navigators within the app who will respond and can reach out and directly do assessments. We do offer services through that. It's access to a resource navigator and also licensed clinicians through that program. So we've really made it more in-house that we can provide that support. But within the RAISE app, we do have crisis resources around if you're experiencing a mental health emergency in this moment, who can you call? So we have a lot of hotlines in the US, so numbers that are 24 hours a day that people can call and talk to a support person. It's not typically licensed professionals, but it's at least someone who can provide kind of in the moment support, or going to the hospital is the other option.
Mais alguma questão? Não, eu também estava vendo aqui no YouTube, não há questões que foram colocadas. Então, com isso, nós vamos aqui encerrando a nossa apresentação de hoje. E eu gostaria, então, de agradecer Marina and Joanna for your enlightening speech today. And I would like you to enjoy your stay in Brazil, and you come back very soon, right? And I would like to please join me in a warm applause to both our colleagues and friends from California. Thank you.